Clinical approach to movement disorders. Herman Morris. gmarist@gmail.com. Servicio de Neurología Jaca. Oviedo, Asturias, Spain. Clinical approach to movement disorders. Introduction. Hyperkinetic movement disorders. Tremor. Dystonia. Tics. Chorea. Myoclonus. Clinical approach to movement disorders. Introduction. Hyperkinetic movement disorders. Tremor. Dystonia. Tics. Chorea. Myoclonus. Objectives. Identify the main categories and subtypes of movement disorders. Describe some characteristic of each movement disorder. Show several videos of the main categories. Approach to differential diagnosis of hyperkinetic movement disorders. Are movement disorders frequent? PD, tremor, tics and dystonia are common conditions. The overall prevalence of PD is 1% in people aged 65 to 85 years, increasing to 4.3% above the age of 85 years. The prevalence of essential tremor is 4% in people aged over 40 years, increasing to 14% in people over 65 years. The prevalence of tics in school-age children and adolescents can be as high as 21%. Clinical presentation. Complex. Variable. Bizarre. Establishing the correct diagnosis can be difficult. Accurate recognition based on clinical acumen is important. Why is important to make correct diagnosis? Correct classification of the type of movement disorder forms the basis for the subsequent diagnostic process. No specific biological marker is available. Many diagnostic tests are available, but these are often expensive, time-consuming or invasive. The diagnostic value of these tests is often limited, especially in early stages of the disease. The investigational workup can be greatly simplified once the type of movement disorder has been defined properly. Avoiding the scattergun approach. Why is important to make correct diagnosis? 2. Adequate diagnosis has prognostic implications. Essential tremor and early PD. Accurate classification also have implications for the patient's family. Differentiating between the different types of movement disorder have important consequences for treatment. Patients with movement disorders can be diagnosed as having a psychogenic disease. Clinical approach to movement disorders. Introduction. Hyperkinetic movement disorders. Tremor. Dystonia. Tics. Chorea. Myoclonus. Classification. Abdo, W. F. et al. Nat. Reverend Neural. 6, 29-37, 2010. Classification. Abdo, W. F. et al. Nat. Reverend Neural. 6, 29-37, 2010. Hyperkinetic disorders. Rhythmical. Tremor or tremor-like disorder. Not rhythmical. Stereotyped. Slow, dystonia. Rapid, motor tic. Non-stereotyped. Chorea, or its relative, valismus. Myoclonus. Reich. Semen Neural 2010 30 15-22. Other movement disorders. Tardive movement disorders, induced by dopamine receptor blocking drugs, emerging typically after chronic treatment and often not remitting, even when the drug is stopped. Psychogenic movement disorders, acute onset, fast progression, movement patterns incongruent with organic movement disorders, distractibility, variability and simultaneous occurrence of various abnormal movements and dysfunctions. Clinical approach to movement disorders. Introduction. Hyperkinetic movement disorders. Tremor. Dystonia. Tics. Chorea. Myoclonus, tremor. Involuntary rhythmic and sinusoid alternating movements of one or more body parts. Rhythmicity. The oscillations occur at a regular frequency. Affect almost any body part including the head, chin and soft palate. Tremor often have a variable amplitude but fixed frequency. Cogwheeling. Jerky, brief contractions throughout the entire range of passive movement, handbrake of a car. The observer feels the underlying tremor, irrespective of its cause. Cogwheeling can be felt in patients with essential or dystonic tremor and PD. There is no additional rigidity, in which case one speaks of cogwheel rigidity, or akinesia. Essential tremor. Parkinson's disease. Longer duration of tremor. Before seeking medical attention. Medical attention within 1 year of onset. Positive family history. Autosomal dominant. 15% affected first-degree relative. Response of the tremor to alcohol. No. Bilateral but asymmetric. Strictly unilateral tremor of the hand or foot. Absent at rest. Activated during maintenance of posture and movement. Maximally activated at rest. 6 to 12 Hz. 4 to 6 Hz. Tremor of the head or voice. A tremor of the chin, lips, tongue. Writing is normal size but shaky. Writing is small but tremulous. Rare foot tremor. Frequent foot tremor, especially unilateral. Monosymptomatic disorder. Remainder of the examination is normal. Bradykinesia, rigidity, decreased arm swing, hypomimia, and hypophonia. Mixed tremor, rest tremor due to incomplete relaxation. Mixed tremor, mild asymptomatic postural or kinetic tremor, primary orthostatic tremor. Leg tremor that is present during standing. A high and pathognomonic tremor frequency of 14 to 18 Hz. Palpated as a rhythmic shivering of the legs, or can be heard through a stethoscope, thumping sound like a helicopter. Wilson's disease. Young people with dystonia, tremor or dysarthria. Diagnosis. Ceruloplasmin low in more than 90%. Serum copper is not a useful screening test. 24-hour urine for measurement of copper. Looking for a Kaiser-Fleischer ring. Autosomal recessive, siblings may be asymptomatic but have biochemical evidence of copper excess. Clinical approach to movement disorders. Introduction. Hyperkinetic movement disorders. Tremor. Dystonia. Tics. Chorea. Myoclonus. Dystonia. Involuntary abnormal co-contraction of antagonistic muscles. Abnormal characteristic postures and movements, produced by slow sustained muscle contraction, which distort limbs, trunk, neck, face or mouth. Sensory trick. Gently touching the cheek to correct torticollis or chewing gum to reduce oromandibular dystonia. Athetosis or distal mobile dystonia. Slow, writhing and irregular movements of the distal extremities, with abnormal posturing. Task specificity dystonia. The movements or postures are predominantly or even exclusively present under specific circumstances, writer's cramp or musician's dystonia. Caution. In patients with leg dystonia who have severe difficulty walking forwards but can walk backwards or run. Bring along the relevant equipment, asking the patient to bring in a home video. Classification of dystonia. Distribution. Focal. Blepharospasm. Cervical dystonia. Hemifacial spasm. Segmental. Multifocal. Generalized. Hemidystonia. Cause. Primary. Dystonia plus. degenerative. Secondary. Age at onset. Early less than 26. Late greater than 26 years. Generalized dystonia. Testing for DYT1, limb dystonia in a young person without other non-dystonic signs. It is autosomal dominant but with reduced penetrance. Types of dystonia. Primary dystonia is characterized by the presence of dystonia only, tremor. Secondary dystonia, other clinical features are present. Dystonia plus syndromes present with a second and relevant neurological feature, Parkinsonism, dopa-responsive dystonia, or sometimes ataxia. Dopa-responsive dystonia. Autosomal dominant functional disorder of dopamine. Mutation of the enzyme GTP cyclohydrolase, which is the rate-limiting step in the production of tetrahydrobiopterin, a cofactor in the metabolism of dopamine. Patients respond to low dosages, 300 mg per day. Child with limb dystonia that typically affects walking. Diurnal fluctuation. Spastic gait, Parkinsonism, or cerebral palsy. Focal dystonia or Parkinsonism in adults. Dystonic tremor when the dystonia is subtle mimic tremor of PD. Arm swing is reduced in dystonia but is not true akinesia. Normal dopamine transporter imaging. Or essential tremor. Subtle dystonic postures, dinner fork posture of the outstretched hand or a tendency for the ulnar fingers or thumb to point downwards with the arms held out. Clinical approach to movement disorders. Introduction. Hyperkinetic movement disorders. Tremor. Dystonia. Tics. Chorea. Myoclonus. Tics recurrent movements stereotyped. Tics are preceded by rising discomfort or urge, sensory tic, that is relieved by the movement, itch and scratch. Tics can suppressed for short periods within attention, leading to a rebound of tics afterwards. Predominate in the face, upper arms and neck. Motor tics, simple tics, complex tics, eye blinking, nose wrinkling, shoulder shrugging, throat clearing, touching things, smelling objects, echopraxia, jumping, phonic tics, repetitive, sniffs, sounds, words, sentences. Tics are often less prominent in the clinical examination room. Videotaping the patient. Caution, dystonic tic. The movement or posture might be slow or prolonged rather than jerky. Stereotypic movements. Complex set of movements that are not long-lasting, patterned, repetitive, purposeless and ritualistic. Occur repeatedly, more continuous and less paroxysmal than tics. Movements are simple, few maneuvers, rocking or headbanging, or more complex, multiple simple maneuvers performed together or in sequence. Patients with autism, mental retardation, Rett syndrome, psychosis, or congenital blindness and deafness. Clinical approach to movement disorders. Introduction. Hyperkinetic movement disorders. Tremor. Dystonia. Tics. Chorea. Myoclonus, chorea word chorea, Greek for dance. Involuntary movements that are abrupt, unpredictable and non-rhythmic, resulting from a continuous random flow of muscle contractions. Movements randomly changes from one body part to another, conveying the impression of fidgeting to the observer. Chorea, a difficult diagnosis. Motor impersistence, fluctuating strength of the grip, milkmaid's grip, or hung-up reflexes, sustained contractions and choreatic movements of the leg after the knee-jerk reflex. Finger chorea is best brought out by the individual canting backwards with their eyes closed and arms outstretched. Patients try to mask their chorea by incorporating the jerks into voluntary movements. Choriatic patients have few subjective complaints, especially in early stages. Huntington's disease from childhood to the 80s. A child may present before the parent is symptomatic. In late-onset cases, a parent have no findings. A parent could have died before becoming symptomatic, or may have been misdiagnosed. Dementia, suicide, psychiatric illness, and institutionalization, particularly in the father because. The important point is that HD should be considered in all cases of chorea, botulism, same pathophysiology and treatment as chorea. Ballistic movements are uncontrollable, severe, mainly proximal, large amplitude choriatic movements. They are usually unilateral, hemiballism, and are classically described after an acute lesion in the region of the contralateral subthalamic nucleus. Monoballism and bilateral ballistic movements due to metabolic abnormalities. Clinical approach to movement disorders. Introduction. Hyperkinetic movement disorders. Tremor. Dystonia. Tics. Chorea. Myoclonus. Sudden, brief, shock-like involuntary movements, which are usually positive, muscle contraction, or negative, due to brief loss or inhibition of muscular. Rhythmic myoclonus can be mistaken for tremor. Tremor lacks the abrupt and shock-like character. Palatal myoclonus/tremor. Myoclonus focal, multifocal, segmental or generalized. Physiological, hypnic jerks, essential, idiopathic or hereditary, epileptic or symptomatic. Cortical, subcortical, spinal and peripheral. Spontaneous, at rest, during movement, action, or provoked by tactile or acoustic stimuli, reflex myoclonus. Mixed movement disorders. Mimics of hyperkinetic MDI. Craniocervical dystonia, torticollis. Retropharyngeal abscess. Atlantoaxial subluxation. Congenital muscular torticollis. Correcting head tilt in cranial nerve palsy, ocular torticollis. Space-occupying lesion in posterior fossa. Sandifer syndrome with head tilt. Dropped head syndrome in neuromuscular disease. Limb dystonia. Contracture. Spasticity. Abnormal posture due to paresis or atrophy. Myotonia or neuromyotonia. Sensory ataxia and or pseudoathetosis. Stiff person syndrome. Tonic spasms. Epilepsia partialis continua. Mimics of hyperkinetic MD2. Facial dystonia. Ptosis or pseudoptosis. Trismus. Hemimasticatory spasm. Hemifacial spasm, tonic component. Myotonia. Tetanic spasms. Apraxia of eyelid opening, levator inhibition. Myoclonus. Tics. Tremor. Fasciculations. Myochemia, involuntary, subtle, continuous, rippling quivering of muscles, which does not produce movement across a joint. Chorea, treatment hyperkinetic movement disorders. Dystonia. Anticholinergic, baclofen, botulinum toxin, globus pallidus internus deeps. Hemifacial spasm. Botulinum toxin. Essential tremor. Propranolol, primidone, topiramate, botulinum toxin, ventral intermediate nucleus deeps. Tics, Tourette's syndrome. Flufenazine, risperidone, botulinum toxin. Chorea, Huntington's disease. Tetrabenazine. Myoclonus. Clonazepam, levetiracetam, piracetam, sodium valproate. Tardive dyskinesia. Withdrawal of the causative treatment, tetrabenazine, for tardive stereotypy, chorea, tremor, botulinum toxin, for tardive dystonia. Lancet Neural 2009, 8, 844-56. Take-home messages. The key to diagnosing movement disorders is establishing the phenomenology of the clinical syndrome. The phenomenology is determined from the specific combination of the dominant movement disorder, the presence of any additional abnormal movements, and any further neurological or non-neurological abnormalities. A range of conditions, both neurological and non-neurological, can mimic various movement disorders, and it is vital not to miss these lookalikes. A systematic approach is recommended when clinicians see patients who present with one or more types of movement disorder.